Imagine a patient drowning in their own lung fluids from a massive, overwhelming bacterial infection.
It is an incredibly terrifying scenario to picture.
Right. And, your logic probably screams that we need to do everything possible to boost their immune system. Just send in the cavalry, right?
Naturally, yeah.
But what if the only way to actually save their life is well, to actively shut their immune system down?
It sounds like a complete medical paradox.
Okay.
I mean, you are introducing an immunosuppressant to a body that is, actively losing a war against an infection.
Welcome to this deep dive. Today we're looking at a stack of recent medical trials and clinical breakdowns to understand a surprisingly dramatic debate in critical care.
Right, the use of steroids,
Yeah.
specifically hydrocortisone, to treat severe community-acquired pneumonia, or CAP.
Exactly. And our goal today is to decode what makes pneumonia truly severe, figure out who actually benefits from this really counterintuitive treatment, and understand the incredibly dangerous territory of using it on the wrong person.
Which is so crucial. And if you're listening to this, whether you're a medical professional catching up on literature or just a curious mind, you have to look at the historical hesitation to really appreciate the gravity of the latest trial data.
Oh, for sure. Because this isn't exactly a new debate, is it?
Not at all. For decades, official guidance, like the 2019 guidelines from the American Thoracic Society and the Infectious Diseases Society of America, they actually recommended against using corticosteroids for severe CAP.
Against it. Wow.
Yeah. The prevailing thought was that the potential for harm, specifically, allowing the bacteria to just multiply unchecked, was far too great.
Which brings us back to that paradox I mentioned. Because if you're listening and wondering why on earth anyone would want to suppress an immune system during a lung infection, let's unpack this.
Go for it.
Treating a bacterial lung infection with steroids feels a bit like fighting a fire with a flammable blanket, right? Because steroids suppress the immune system.
Right, exactly.
Why would we ever want to do that when the body is fighting an infection? But from what these sources detail, the bacteria isn't always the primary thing doing the lethal damage.
That is the crucial realization here. What's fascinating is that when pneumonia reaches a severe stage, the actual threat shifts.
How so?
Well, the host's own immune response becomes the primary danger. The body detects the invading bacteria in the lungs and just mounts this intense pulmonary and systemic inflammatory response.
Okay, I picture it a bit like a SWAT team responding to a single burglar in a house. The burglar is the bacteria.
Okay, I like this.
But the immune system SWAT team shows up and just starts throwing heavy explosives through every single window. They might get the burglar, but they are going to completely destroy the house in the process.
That is a highly accurate way to visualize a cytokine storm.
A cytokine storm, right?
Yeah.
Right.
The body sends out this massive flood of inflammatory proteins. And this excessive, uncontrolled inflammation causes the delicate air sacs in the lungs, the alveoli, to fill with fluid and immune cells.
Which means you can't breathe.
Exactly. It leads to severely impaired gas exchange. The oxygen you breathe in simply cannot cross over into the bloodstream.
Wow.
And eventually, this unchecked inflammation spreads throughout the entire body, progressing to sepsis, massive drops in blood pressure, and multi-organ failure.
So the body essentially destroys itself in its attempt to kill the bacteria.
It does. And that is exactly where steroids come in. Hydrocortisone acts as a powerful immunomodulatory agent.
So it's the negotiator that walks in and calms the SWAT team down.
Right. Stopping the explosive damage and allowing the lungs to remain intact. It stops the friendly fire.
That makes so much sense.
By dampening that extreme inflammatory response, hydrocortisone allows the antibiotics time to actually clear the bacteria without the body's immune system inadvertently killing the patient first.
But, and I think this is a huge but, the sources are very careful to distinguish this from the kind of pneumonia where you get a prescription for antibiotics, go home, and just rest on the couch.
Oh, absolutely. This biological overreaction doesn't happen in mild cases. Not at all. And that distinction is actually where decades of previous clinical trials failed.
Because they were mixing up the patients.
Exactly. Historical data was often contradictory because researchers mixed moderate pneumonia patients with severe pneumonia patients in their trials.
Oh, I see.
If you give a steroid to a patient with a moderate infection, you're just suppressing their immune system for no reason because they aren't experiencing that deadly cytokine storm.
They don't have the SWAT team throwing explosives.
Precisely.
Yeah.
The benefit is entirely restricted to severe AKP.
But the word severe can feel kind of subjective, though. I mean, if a patient feels terrible, they think their case is severe.
Of course they do.
So how do the sources objectively define the threshold where this treatment actually becomes life-saving?
Well, the clinical criteria are incredibly strict. To be categorized as severe, a patient typically has to meet one of a few specific markers.
Okay.
The first is a pulmonary severity index, or PSI, score strictly greater than 130.
Right, the PSI. That's a complex scoring tool that ER doctors use, right? Factoring in age, coexisting illnesses like heart disease, vital signs upon arrival.
That's the one. And a score over 130 means they are in the absolute highest risk category for death.
Wow. And what's the other marker?
Alternatively, severity is defined by the immediate need for advanced ventilatory support. We're looking at patients who require mechanical ventilation or those placed on a high-flow nasal cannula.
With specific oxygen parameters, right?
Yes, requiring an inspired oxygen fraction, the FiO2, greater than 50%, alongside a PO2 to FiO2 ratio of less than 300.
Okay, let's put those numbers in perspective for you if you're listening, don't have a medical background. Imagine breathing in a massive continuous blast of pure oxygen.
Right.
But your lungs are so damaged, so thick with inflammatory fluid, that almost none of that oxygen is crossing the barrier into your bloodstream. You are essentially suffocating while hooked directly to a pure oxygen supply.
It's awful. These are patients hovering right on the brink of complete respiratory collapse, the sickest of the sick.
And because that definition of severe was finally standardized, researchers were able to cut through all that historical noise. Which leads us to the centerpiece of today's deep dive.
The CAPE COD trial.
Yes. Published in the New England Journal of Medicine in 2023. They took 800 patients in French intensive care units who met those exact strict criteria for severe CAP.
Yep.
Half received a continuous intravenous infusion of hydrocortisone at 200 milligrams per day, and the other half received a placebo.
And the methodology was really rigorous. It was a double-blind, randomized controlled trial. Neither the doctors nor the patients knew who was getting the steroid.
And they intervened early, too.
Crucially early.
Yeah.
Typically starting the infusion within 15 to 20 hours of the patient being admitted to the ICU.
So lay out the primary outcomes for us, because the survival data is what fundamentally shifted medical guidelines worldwide.
It really did. In critical care trials, you usually hope for a tiny fractional improvement in survival. But the CAPE COD trial nearly cut the mortality rate in half.
In half? That's insane.
The 28-day death rate was 11.9% in the placebo group. In the hydrocortisone group, it dropped to 6.2%.
Wow.
Seeing an absolute risk reduction of almost 6% in mortality is a profound achievement in intensive care medicine. It means that for roughly every 18 patients treated with this protocol, one life is entirely saved that would have otherwise been lost.
And the physical toll it saves the survivors from is just as staggering if you look at the secondary outcomes.
Oh, absolutely.
For the patients who arrived at the ICU struggling to breathe but hadn't yet been put on a ventilator, the steroid group saw a massive drop in the need for endotracheal intubation.
Right.
It went from nearly 30% in the placebo group down to 18% for those getting hydrocortisone.
Which is a massive victory. Avoiding mechanical ventilation is huge. Intubation requires sedating a patient into a medically induced coma. It leads to rapid muscle atrophy, increases the risk of acquiring secondary infections directly from the ventilator tube, and often results in long-term cognitive and physical deficits.
Months of rehab.
Exactly. Keeping a patient off a ventilator doesn't just save their life, it preserves their quality of life.
The trial also showed that patients receiving hydrocortisone had a significantly lower need for vasopressors.
Yes.
Those are the intense medications pumped into a patient to artificially squeeze their blood vessels and prop up their blood pressure when they go into septic shock, right?
Right. And this makes perfect pharmacological sense. Hydrocortisone doesn't just reduce inflammation, it also has mineralocorticoid properties.
Meaning what exactly?
Meaning it helps the body retain sodium and water, which naturally supports blood pressure. It acts as a sort of multi-tool in the ICU.
So what does this all mean? Well, based on this robust data, major medical societies like the Society of Critical Care Medicine in 2024, they did a complete 180-degree turn.
They did.
They flipped from recommending against steroids to strongly recommending them for severe CAP.
Which is a huge shift.
Massive. But even within this group of severely ill patients, the data presents a bit of a biological puzzle. Some patients respond to the steroids beautifully, while others just don't seem to get the same dramatic benefit.
Which brings us to the underlying biology, specifically a biomarker called C-reactive protein, or CRP.
The sources highlight this as a major clue. CRP is a protein manufactured by the liver in direct response to inflammation in the body, right?
Exactly. It's a classic rapid blood test used to see if the immune system is currently throwing a massive fit.
A SWAT team explosive detector.
Exactly. And the clinical breakdowns of the CAPE COD trial revealed something truly fascinating. The mortality benefit of hydrocortisone was most pronounced, in fact, almost exclusively concentrated, in patients who had a CRP level strictly above 15 milligrams per deciliter.
Which, depending on your hospital's lab units, might be reported as 150 milligrams per liter.
Right.
That is an exceptionally high level of inflammation. It basically proves the cytokine storm is happening.
It acts as a biological confirmation. It proves the patient's immune system is in overdrive, which means the immunomodulatory hydrocortisone is going to be highly effective.
Okay, hold on though. I'm stuck on this CRP thing, and I kind of want to play devil's advocate here and challenge the practicality of this.
Go for it.
If I'm an ER doctor and a patient comes in crashing at 2 a.m., I'm under immense pressure. They are struggling to breathe, their oxygen is plummeting, and I get a portable, kind of blurry chest x-ray that shows a shadowy patch.
Very common scenario.
Right. I don't have time to wait for a lab test to process and tell me if their inflammation is exactly 15 milligrams per deciliter. Why not just give the steroids immediately to be safe? What's the actual harm in a better safe than sorry approach?
The harm is that a blurry chest x-ray and severe shortness of breath do not guarantee the patient actually has pneumonia.
Wait, really?
Oh yeah. In a high-pressure emergency department, that shadowy patch on the x-ray could secretly be acute heart failure, where fluid is backing up into the lungs from a weak heart.
Oh, wow.
It could be atelectasis, where a section of the lung has simply collapsed. It could be a lung injury from accidentally inhaling stomach acid.
So if you just throw steroids at any blurry x-ray without biochemical proof, you might be treating heart failure with powerful immune suppressants.
Which offers zero benefit to their heart failure and introduces massive physiological risks.
That makes a lot of sense.
The CAPE COD trial was successful because it had exceptionally strict exclusion criteria. They weeded out the heart failure, the collapsed lungs, the aspiration injuries. They ensured every single patient in that trial actually had true, severe bacterial pneumonia.
And in the real world, outside of a heavily monitored clinical trial, relying on a fast biomarker like CRP is your safeguard.
Exactly. It gives the clinician objective proof that they aren't just guessing in the dark. It proves the patient actually has the specific inflammatory profile that requires a steroid, basically preventing doctors from treating the wrong disease.
And that diagnostic discipline is vital, because when we examine another major trial from the sources, we see exactly why assuming steroids are a universal miracle cure is just a really dangerous mindset.
Right. Let's pivot to the ESCAPE trial.
Yeah. This one didn't make the glamorous front-page headlines like CAPE COD did, but it is deeply important for understanding the limits of this treatment.
It really is. The ESCAPE trial was conducted across U.S. Veterans Affairs hospitals.
So a very different demographic.
Very different. The patient population was 96% male and 83% white. And second, they used a completely different steroid, methylprednisolone, administered over a tapering schedule.
And the results of ESCAPE were incredibly disappointing compared to CAPE COD. Looking at mortality at 60 days, there was no statistically significant difference between the groups.
No.
The death rate was 16% in the steroid group and 18% in the placebo group, a 2% difference that mathematically just registers as noise.
Right. And it forces us to sort of synthesize the conflicting data. Why did hydrocortisone save lives in France, but methylprednisolone failed to do so in the U.S. VA system?
Well, you mentioned earlier that hydrocortisone has those mineralocorticoid blood pressure supporting properties. Methylprednisolone doesn't have that to the same degree, right? It's primarily just anti-inflammatory.
Exactly. That pharmacological difference likely plays a substantial role. Hydrocortisone addresses both the inflammation and the shock-induced blood pressure drops simultaneously.
Okay, that makes sense.
Furthermore, if we connect this to the bigger picture, the ESCAPE trial struggled heavily with patient recruitment and was stopped early.
Ah, right.
A trial that is halted prematurely is often underpowered, meaning it lacks the statistical weight to detect a small but potentially real clinical difference.
There is also a glaring issue of publication bias that the clinical breakdowns highlight. The positive, practice-changing CAPE COD trial was published in just a year and a half.
Yeah?
The ESCAPE trial, which showed negative or neutral results, took 6 years to get published.
6 years. It shows a systemic flaw in medical literature where positive results are rushed to the front, while trials showing no difference just languish in peer review.
Even though knowing what doesn't work is just as critical for patient safety.
Absolutely. Which perfectly transitions into the very real physiological risks of this treatment.
Yeah.
If we are giving critically ill patients powerful immune-suppressing drugs, we really have to look for the collateral damage.
Right, because historically the medical community feared that shutting down the immune system would cause secondary hospital-acquired superbugs to invade or cause massive gastrointestinal bleeding.
So, did the trials show the flammable blanket causing secondary fires?
Well, interestingly, no. In the CAPE COD trial, the rates of hospital-acquired pneumonia, bloodstream infections, and severe GI bleeds were statistically identical between the hydrocortisone and placebo groups.
Which is really surprising.
It is. The highly selected nature of the patients meant the drug calmed the cytokine storm without completely obliterating their baseline defenses.
However, there was one undeniable significant adverse effect. Massive spikes in blood sugar. Hyperglycemia.
Steroids are notorious for this, aren't they?
They are. They trigger the liver to produce more glucose and simultaneously cause the muscles to become resistant to insulin. The patients receiving hydrocortisone required significantly higher daily doses of insulin by day 7 compared to those getting the placebo.
Wait, just to manage their blood sugar?
Yes,
Yeah.
to manage the hyperglycemia.
I mean, I guess it's a manageable side effect when a patient is in an ICU with nurses checking their blood sugar every hour, but it is a severe metabolic disruption.
It is.
And it brings us to the ultimate warning of this entire deep dive. You cannot take a treatment that works for the absolute sickest, brink-of-death patients and try it on moderately sick patients hoping to prevent them from getting worse.
You really can't. Expanding the use of this protocol to milder cases shifts the risk-benefit profile unfavorably.
Right.
If a patient has mild pneumonia and a low PSI score, their own immune system is generally managing the infection effectively without destroying the lungs.
So if a doctor introduces a steroid to that mild patient, they are suppressing a perfectly functional defense system. There is no deadly cytokine storm to calm down.
Exactly. They expose the patient to massive blood sugar spikes and potential secondary infections for absolutely zero clinical gain.
It actively harms them. And there is an even more severe contraindication detailed in the evidence, which is influenza.
This is critical. The CAPE COD trial explicitly banned anyone who tested positive for the flu from participating, because evolving clinical evidence demonstrates that administering systemic steroids to patients suffering from influenza-induced pneumonia can cause profound harm, accelerating viral replication and increasing mortality.
Think about what that means for an ER doctor in the middle of January. A patient comes in crashing with severe pneumonia. The doctor knows hydrocortisone could cut their risk of dying in half if it's a bacterial infection.
Right.
But if it's the flu, that same bag of hydrocortisone could be fatal.
They cannot act blindly. They must wait for the viral respiratory swab to come back. The temptation to intervene immediately has to be balanced by the absolute necessity of diagnostic accuracy.
So if you take away anything from this exploration of the data, let it be the power of asking the right questions. If you or a loved one are ever sitting in an ICU waiting room while someone is battling severe pneumonia, you now understand the exact mechanics of what the medical team is debating.
You understand that pneumonia is not a single uniform disease. To ask the intensive care team about the severity markers. Are they tracking a high pulmonary severity index?
And, to ask about the biomarker. What is their CRP level? Is there laboratory proof of massive systemic inflammation that justifies suppressing their immune system?
And most importantly, to ask if they have definitively ruled out an active influenza infection before introducing steroids.
Understanding those mechanisms gives you a compass in a highly complex medical landscape. But before we finish, there is one final, incredibly provocative data point buried in these trials that challenges everything we think we know about standard care.
Oh, this is fascinating. It stems from the demographic gap between the two trials we analyzed.
Right, the ESCAPE trial conducted in the VA system was 96% male, and it demonstrated no mortality benefit from the steroids.
Meanwhile, the CAPE trial was conducted in the general French population and included about 30% women.
And when you look closely at the supplementary data of that trial, it hints at potential sex-based differences in survival. It suggests that women may have responded significantly better to the hydrocortisone than the men did.
It raises a profound biological question. Could biological sex dictate how an individual's immune system structurally reacts to a bacterial infection?
It's It's crazy to think about.
Historically, females have been vastly underrepresented in clinical research, leaving huge blind spots in our understanding of how powerful therapies affect different physiologies.
It makes you wonder if the future of intensive care will move beyond just checking inflammatory markers like CRP. What if, 10 years from now, standard care means giving fundamentally different immunomodulatory drugs to men and women facing the exact same bacteria?
It suggests our current approach to medicine might still be far too generalized. The scientific process is just a constant refinement. We're always zooming in closer.
We really are. Well, thank you for joining us on this deep dive. Keep questioning the consensus, keep looking for the mechanisms behind the statistics, and remember that in medicine, the most powerful tool isn't always the strongest drug.
True.
Sometimes the most powerful tool is the discipline to wait for the one biomarker that tells you exactly when to use it.